guest, Professor Sivagnanasundaram, the guest of honors, Professor Nihal Thomas and Dr. Palita Mahipala, and our chief special guest, my teacher, Gowribahan. Consultants, Vice Chancellor, Deans, my mentors, teachers, colleagues, friends, ladies and gentlemen, good evening to you. Redefining Urological Surgery, a single center experience, reflecting the trends, reflecting the changing trends. Prof.C.Sivagnanasundaram is an eminent academic, physician, and a pillar of medical education in Northern region. He graduated from 1955 from University of Ceylon, and his legacy of medical education started after 9 years of healthcare provider job in Ministry of Health. He started his career as an outstanding teacher from Faculty of Medicine, University of Peradeniya in 1964. He is the founder professor of community medicine, University of Jaffna from 1978. He continued to serve for a quarter century even after his formal retirement. He served as a dean in Faculty of Medicine and member of University Council for 14 years. His contribution to the Faculty of Medicine is vast and varied. The name of Nandi was given by a legendary Rajaji of Tamil Nadu. It's perfectly suited for his career as a symbol of knowledge. The Nandi, a symbol, occupies the center of University of Jaffna as well. He's a man with many talents. He worked as a consultant in WHO in several countries, made an immense contribution to Tamil literature, authoring wide popular short stories and novels in Tamil. He showcases linguistic skill in his writings. He even acted in a Sri Lankan Tamil movie called Ponmani in 1977. His knowledge in medical statistics was unparalleled. He attributed this skill to his esteemed teachers at University of London. He published an invaluable book called Learning Research in 1999, which is a gift for medical students and the doctors those days. A new era in urology, shifting from open surgery to the precision intervention. This photo of a patient from a same pathology in 2 eras of Jaffna Urology Department. The talk is principally based on this picture. Urology had a profound transformation in last 2 decades. A remarkable shift from extensive open incision to the intricate, minimally invasive intervention. This evolution has dramatically reshaped the global standard of patient care. The Sri Lanka adapt this change even with inherited challenge. There are compelling evidence of randomized controlled trials and meta-analysis confirm these benefits. They matches the traditional methods in oncological efficacy and significantly reduce the blood loss, complications rates, and the post-op pain. So these advancements represent more than a just technological process. They reflect a new surgical philosophy that focuses on organ preservation, patient-centered care, and precision-driven intervention. Despite of these inherent systematic challenges, Sri Lanka has steadily embraced these international trends. The adaptation of laparoscopic and endourological techniques, which promises the greater precision, improved efficacy, and superior patient outcome for the population. The evolution of urological surgery from ancient incision to the modern precision. In the earliest procedure, surgical procedure, circumcision, was documented in 2400 before Christ in ancient Egypt. Later, the Hindu surgeons, 600 before Christ, have described a suprapubic incision for the stone removal. The rise of specialized lithotomists in 17th and 19th century, they are known as stone cutters, who perform perineal lithotomies across the Europe. Then later, the gradual refinement and surgical techniques has approaches over next 2 centuries. In 1877, Maximilian Nitz and Joseph Lister has developed a first practical cystoscope. This invention revolutionized the urological diagnostic and the treatment, the birth of modern urology. In the late 19th centuries, the urology emerged as a distinct surgical specialty with its own society and the journals. In the 20th century, the open nephrectomies, prostatectomies were the standard of care. The significant drawbacks in the procedure were the blood loss and the hospital stay, complications rate, especially wound infection, moves up to 20%, and the recovery is slow. This high mobility motivate the search of better techniques. The first pioneering breakthrough in the minimally invasive revolution was discovered by the Ferguson and Johansson from Sweden in 1976, who has invented the first percutaneous nephrolithotomy. In the initial days, they keep the patient in the ward for several days to dilation of the tract which they puncture. We do it in one step now. Can understand everyone the difficulty of direct visualization through the scope on those days with the picture. And they publish their work as well. The second pioneering breakthrough, the first laparoscopic nephrectomy, was done by V. Kleiman and team from California. It's a pioneering minimally invasive surgeon who has invented this technique. And the photo on the left was taken in his first laparoscopic nephrectomy. The other minimal invasive urological techniques such as robotic assistance and endourological procedures such as ureteroscopies and image-guided interventions have minimized the physiological disturbance while achieving the equivalent or superior clinical outcomes become the primary objective. There are robust data support this shift. The key benefits are low blood loss, less post-operative pain, shorter hospital stay, faster recovery, and lower wound infection rate, and equal oncological efficacy. The innovation, the technology has supported this change. The high definition 3D visualization for the superior anatomical recognition, an advanced robotic instrument provides greater dexterity, and sophisticated lasers and the energy devices enable for the precise tissue dissections. As a result, we can have a safe, more reproducible surgery. In the patient perspective, they give a better aesthetic appeal, faster functional recovery, and improved quality of life. So now this minimal invasive procedure has completely wiped out the open surgery? The answer is no. The open surgery remains crucial for the surgical education. It is fundamental for developing an anatomical understanding, tactile feedbacks, and crisis management skills in uncontrollable bleedings. So in all the guidelines, the expert consensus, the trainee should be achieve competency in open surgery before they transform into minimal invasive techniques. This shift from open to minimal invasive urological is supported by the robust evidence. This delivered the superior perioperative outcomes without sacrificing the efficacy. The journey from the ancient incision to the modern precision has fundamentally improved the patient care. Evolution of urological surgery in Sri Lanka. The humble beginnings to the minimal invasive establishment. In 1955, Dr. G.N. Pereira, a Sri Lankan first urologist, established the foundation. A modest 10-bed urology unit was started in National Hospital of Sri Lanka. It shared the spaces with obstetricians and the general surgeons. They rely exclusively on the open procedures and rudimentary diagnostics. Later, in National Hospital of Sri Lanka, the urology had a separate building on urology and nephrology. A similar 10-bed urology unit was later established in Jaffna in a constrained situation only this year. Hopefully, our future also looks bright. The discipline began to flourish after 1980s, where the institutional training through a postgraduate institute of medicine, the nation's first board-certified urologist, Dr.A.T.Gowribahan. Currently, the Sri Lanka boosted with 38 board-certified urologists. They provide nearly universal access to the specialized urological care across the island. This represents the significant growth from a single pioneering unit. Minimally invasive surgery had a slow start. Globally, minimal invasive adaptation accelerated in 1990s. In Sri Lankan public sector, the uptake was delayed. In pre-2015, the urological laparoscopic work were limited to the diagnostic laparoscopy. Sri Lankan, even though Sri Lanka reclaimed the PCNL done in 2003 times, but the first Sri Lankan urologist who performed the percutaneous nephrolithotomy, Dr.A.T.Gowribahan, my trainer and mentor, who was in the audience today. It's a proud moment for me. And he has published his early experience in 2019. The first laparoscopic nephrectomy is done in Sri Lanka in 2007 under Dr. Neville D. Pereira in National Hospital of Sri Lanka. In the post-2015, a new generation of urologists returning with their cutting-edge international training. They brought new skills and techniques to the public health system. Even they returned with the skills and the enthusiasm. The infrastructural limitations such as sporadic equipment availability, inconsistent maintenance, fear competitions for the operating theatre time. Despite of these challenges, the determined young specialists have shown remarkable resilience to start laparoscopic programs. So the challenges that we face in a diagram explanation, this is an ideal setup for the PCNL and the setup of Jaffna Teaching Hospital, where the general surgical towel used as a drape. There are time in my training with the PCNL surgeries were postponed due to the non-availability of drape, but we never stop with that. When you carefully observe, the collecting bag of dripping saline is a bucket and the Macintosh, where the ideal setup has collecting bags. Thank you for the invention. The same happens in laparoscopic nephrectomy as well. When you compare the ideal setup, the mobility of the display and the quality was not comparable with us. Again, the drapes. The quality of drapes are not matching with that. But we never stop. We continue to improve. Currently, the PCNL surgery in Sri Lanka is done in all parts of Sri Lanka. The blue dots have high volume center where they do more than 100 PCNLs per year, and the red dots are the low volume center. They do less than 100 PCNLs per year. When you come to the laparoscopic establishment, it's in the early stage, where the blue dots give the regular and high workload center, where regularly do laparoscopic service, and the red dots are early centers, they do non-regular laparoscopic works. The journey has been from the Dr. Pereira's fundamental 10-bed unit to the cups of minimally invasive era. The progress is driven by the determined specialist overcoming the infrastructural challenges. The future of Sri Lankan urology is bright, built on the legacy of resilience and the commitment to advance patients' care. Jaffna stands as an inspiring testament to adaptability and the innovation. Despite formidable barriers, surgeon has successfully integrated laparoscopic technique into their routine practices as a model of success. We, as a surgical fraternity, have lost two eminent surgical personalities, have grown from this resilient ground. Dr. V. Sudarshan and Dr. T. Nimal Ranjan in last month. The establishment of urological surgery in Jaffna. The urology cases were initially managed by institutional pioneering general surgeons. The standard of care is an open surgical procedures. The open prostatectomies, open pyelolithotomies, open ureterolithotomies, and open nephrectomies. Few general surgeons with special interest in urology began to perform basic endourological procedures as their routine practice. This initial foray into a minimal invasive technique was facilitated by procurement of instruments through their own personal initiatives. This marked the first crucial shift away from purely open surgery. Dr. Gowribahan, who is in the audience as well, who's performed the first Jaffna transurethral resection of prostate in 1998. Those days, the local paper published it as a Katti Indri Rathamandri as well. 2012 is a pivotal year with an appointment of first board certified urological surgeon to the Jaffna Teaching Hospital. The initial challenges were extremely limited resources, a single room with one supporting staff, a health assistant, Dr. B. Sadisa. Through the relentless effort of over 9 years, the unit was progressively developed. It transformed from a single room into the fully developed urology center. Acquisition of modern endourological and laparoscopic instrument. Currently, it has a high volume minimal invasive care. It handles high volume of case efficiently, functioning as a major referral center including pediatric PCNN. 3 urological surgeons, including 1 from the University Surgical Unit. The advanced urological procedures such as laparoscopic urological surgeries and supine percutaneous nephrolithotomies done routinely. This reflects a full integration into a modern, minimal invasive urological care. So our study was a retrospective study at Teaching Hospital Jaffna in the minimal invasive urology. To review the performance of 2 key minimal invasive procedures, laparoscopic nephrectomy and supine percutaneous nephrolithotomy, to assess the feasibility and the safety in this technique, these techniques in this setting. It's a retrospective clinical review. The data collected from 2021 to 2025. All procedures were performed by a single dedicated surgeon. And the data is collected with a dedicated team, including medical students, research assistants, and the junior doctors. The outcomes and the trends of laparoscopic nephrectomy. We had a small video clip which explaining what we do in the theaters for the audience. So the patient position in lateral position with marking on port size and WHO checklist done, and the first port entry through the open Hassan techniques and the other ports under the direct visions. We do 4-port technique. Once the renal hilum dissected, the artery dissected, and then we apply 2 Hem-o-lok clip to the patient's side to control the bleeding and the safety, and one on the renal side to control the back bleeding. Once the artery clamped completely, we divided it. You can observe the scissors is not properly cut in. These are the resource constrained setting that we work daily. And the vein clamp with the same technique as well. Once the vein is completely divided, the specimen retrieved through the loin incision, and the specimen displayed at the end of the video as well. So the gradual but significant shift from the open to minimally invasive urological surgeries in Sri Lanka. The study focused on laparoscopic nephrectomy to contribute the growing body evidence, local evidence supporting the surgical transition. Aligns with the worldwide adaptation of minimally invasive techniques for the better patient outcomes. It's a retrospective review of 41 laparoscopic nephrectomies, the procedure performed between 2022 to 2025, and the data was collected from the paper-based clinical records, mainly from the BSTs and the clinical books and the operative notes. The data was collected by the trained team. The analysis by the IBM SPS Statistics version 23. And the patient demographics and the case distributions. We have 61% of malignant tumors and 39% of benign conditions such as non-functioning infected kidneys. Males are predominant in number, 66% representation. When you concentrate on malignant cases, we have laparoscopic radical nephrectomy 76% and the laparoscopic nephrouretrectomies for 24%, which we do for transitional cell carcinoma. We take out the ureter completely as well. The tumor size, the mean tumor size is 6.63 centimeters and ranging from 2 to 14 centimeters. The most common location is upper pole, 40% representation. The urothelial carcinomas and the papillary carcinoma and cystic neoplasm. When you are assessing the intraoperative and postoperative outcomes, the conversion rate to the open surgery happens in 16% in 4 patients. The reason behind is the bleeding and the technical difficulties for 3 cases and 1 for a planned open, a combined case with gynecology team for the ovarian tumor on the same patient. The estimated blood loss on average is 301. The malignant cases a little bit high, 338. And the benign cases is 154. The blood transfusion required only the 7 patients, representing 28%, and the mean operating time is 3 hours, ranging from 2 hours to 2 hours and 5 minutes to 6 hours. The average hospital stay of the patient is 3 days. The complications and the oncological safety. So most of them are grade 1 and 2 complications, 85%, and the main complication that we got is the wound infection, representing 12%. The other complications are urine leak and bowel-related complications and fever. We have one mortality which is happened in day 4 due to the cecal volvulus. The oncological safety, we have negative margin for 88% of the cases, and 2 cases have positive margin mainly due to the renal vein thrombus. Tumor spillage happens in one tumor which is 14 centimeter during the procedure. The local recurrence is 2 cases happened in 6 and 1 year respectively. So, as a conclusion, the study demonstrates that laparoscopic nephrectomy is a feasible and safe procedure in the resource-constrained setting like Sri Lanka. With growing expertise and the institutional support, it's rapidly become the preferable alternative for the open surgery. Represent the significant milestone in the advancement of urological practice in the country. It successfully aligns Sri Lankan surgical care with the global trends toward the minimal invasive techniques. The second study is a comprehensive evaluation of supine PCNL in resource-constrained setting from 2021 to 2025. We had a similar small video to explain what we do in the theater to play the audience. So we put the patient on the supine position and the site was marked, and the assistant put after the cleaning drape, the assistant put the retrograde catheter, and you can visualize the stone and the catheter in the kidney, followed by a retrograde pilogram where the kidney and the needle access gained to the upper calyx, and then it confirmed with the free flow of contrast through it, and the tract was dilated to the bigger tract for the nephroscope, and then it confirmed with the free flow of contrast through it. And we use a bucket to collect the spillage of saline, and the stone found with the nephroscope and laser into the particles and taken out. And the area of stone was fully cleared after the procedure. And the anti-growth stenting was done after the procedure. These are the stone specimens. So why the supine PCNL? The rationale. The advantage over the prone PCNL is shorter operating time, reduced anesthetic-related complications, and comparable stone-free rates. Improve the ergonomics for the surgeons. The study aimed to evaluate the feasibility and the safety and the outcomes of supine PCNL as a standard of care in our setting. Again, it's a retrospective analysis of 290 supine PCNL cases, where the final cohort is decided to 191 cases due to the inadequate data of 103 cases. The data sources were electronic and the paper-based records, and operative notes, and the anesthetic charts. The analysis through the IBM SPSS 23 version. The outcome measures are demographics, stone characteristics, operative details, complications, and stone-free rates and the hospital stay. The patient summary. Our mean age of the patient is 45 years, which is a very productive year of a human being. A pediatric cases representing 4.2% and an equal distribution of both side kidney. And the mean stone size is 2.2 centimeters. And we have 7.9 cases, 7.9% of stagone calculus. Again, the male predominating the disease. The intraoperative outcomes and the efficacy. We have 76% of complete clearance of stones and 23% of residuals, which is slightly higher than the international standard. And the supine PCNL used as 100%, and the tract size varies from 24 to 26, and a single track used in 90% of the time, and the mean operating time is 78.8 minutes. JJ stent used as a unit policy in almost all cases in the post-operation. The safety profile. 73% of the cases are uneventful. They have no issues. They went home on the day 2. And the bleeding is the major complication, and we have abandoned the procedure in 7.3% due to the technical difficulties and the other complications. The post-operative complications again is about 81% of the people have no complications. They went home on the day 2. Again, the bleeding is the major complication post-operatively as well. The other complication is a fever, which is 2.1%, which is very much low compared to the other urological procedures such as ureteroscopies. So the key correlations are long hospital stay for elderly patients. When the stone size is more than 3 cm, have a long operating time and high bleeding risk, and more residual fragments, and multiple tracts, which use roughly about in 10% of our patients have significant bleeding and longer hospital stay. We have pediatric cases of 8, which is representing 4.2%, have favorable outcomes and high clearance rate, no major complications. Why the PCNL become an important in urology? The stone disease, consisting about 80% of the urological practice in Sri Lanka. It's a high prevalence, large, complex and hard renal stones necessitate advanced techniques. In low middle income countries, the design of nephroscope, which is more durable compared to the fragile flexible ureteroscopies, a critical factor in the resource constrained environment. So the trends over the time from 2021 to 2025, supine PCNL is in the rising trends, and the stone-free rate is remain stable, even the tract size getting smaller and smaller. And the hospital stay is slowly coming down, but the post-operative complications are significantly go down because of the refinement of techniques and the improvement. So, as a conclusion, supine PCNL as a new standard of care demonstrates safety, efficacy, and cost effectiveness. The robust technique perfectly suited for the resource-constrained settings. The knowledge dissemination through the enhanced digital platforms and online urological communities have enhanced this procedure. And the future direction call for multicentric studies to validate the advantage and establish the standard protocols. So the impact of minimal access urological surgery in surgeons and the future of training. The expands treatment options, enable to proceed the complex procedures that we previously only possible with open techniques. They have a superior ergonomics where the physical stress to the surgeons are very minimal when compared to the laparoscopic surgery to the open surgery, where the neck and the back were safe. The enhanced visualization, the magnifying high definition view of a surgical field, where you can see the renal vein and the gonadal vein and the adrenal vein, which was clearly seen in laparoscopy, which is very difficult to see in the open surgery. The stimulation-based training allows for the practice in risk-free environment and shorten the learning curves for the more efficient surgical procedure. procedure in the field. So what are the challenges we faced? The barriers to the adaptations and the path forward. We have four pillars of challenges: the equipment and the maintenance, inadequate, unreliable instruments, and the resource allocation, fair competition for the limited ward spaces and operating room resources allocations. The human resource shortage of trained surgical teams and the supporting staff. The training and education is critically underdeveloped infrastructure for the skill acquisition. So, the core recommendation, the cost-based analysis for the Sri Lanka for a minimal invasive surgery compared with the open surgery, which is a mandatory call to review. So, conduct a local cost studies. Jaffna to conduct a meticulous economic evaluation to build a local evidence-based. Invest the technology, advance minimal access technologies, including robotic systems. Foster specialized training, develop and invest on a dedicated fellowship programs and stimulation centers to build the skilled workforce. To ensure the Sri Lankan healthcare system meet the global benchmark in minimal invasive surgical care. So as a conclusion, minimal invasive urological surgery has our experience have confirmed that the laparoscopic nephrectomy and the supine PCNL are safe and effective techniques. They demonstrate high quality surgical outcomes are possible even in the resource constrained settings. This approach aligns with the global shift towards the prioritizing the patient recovery, comfort, and the quality of life. In a bigger picture, represent the fundamental move towards the less invasive method in surgical care, and the success stem from adapting the global standards to our local realities and the constraints. Our journey is a model for the similar institution in Sri Lanka and other low-middle income countries. When an average person meeting this incredible journey, the acknowledgement is lengthy. Mukundan sir, a school teacher, and my second father, who prayed to God and bless me during the crucial exams. Thank you for the blessing and presence. Dhanabalan sir is a mentor in character and personality, the most powerful person I have admired in my life so far. The Gunaseelan sir, in every cricket match, there is a game changer. I would say he is the game changer in my life. He planted in me a seed of academic spirit, which has now grown and give me a confidence to stand before such an esteemed audience. Thank you, sir, for your guidance. Dayabarananna, a kind brother who shaped me from a messy playground kid into an organized learner. A good teacher explains, a superior teacher demonstrates, but the great teacher inspires. Jayaratnam sir has not only inspired me, but also many of my batchmates who are today the specialists in various fields. Lalit Parra sir, he is a beacon in my surgical career. In my difficult times, he told me, Gowri, sometimes things go wrong beyond your control, but once the time changes, everything will fall in your favor. These golden words gave me a I delivered an oration in my own urology work in my motherland. Thank you, sir, your presence and support. PRC sir, he's taught me a true surgical stamina, a long night list followed by an early morning rounds and a routine morning theatre list marked the toughest period of my career. Thank you, sir, for building my strength and discipline. Nandasena sir, a trainer who taught me his hand skills rather than his words. He spoke only 50 sentences in my entire urological training of 2 years. I hope I have absorbed valuable skills you have generously shared. Thank you, sir, for your guidance and invaluable presence. Sudeshan Anna, one of my hero, coach and trainer, has continuously inspired me with his extensive support in developing urology in Jaffna. And my research team, my colleagues, Dr. Sivagnanasundaram, who is a junior teacher for me, he always open for discussions in any aspect. And Nishanta Veerasinghe, who is a man who gives the minimally invasive spirit in me to continue this work. And Tanushan and Balagobi, always there to give a hand for me. And my medical officers, Artika, Gajandan, Dev, and Pavitra, who have been assisting my surgery. And the research team, especially Milojan and Victoria, who have done a tremendous work in editing in my manuscript and the slides. The Urology Department of Jaffna Teaching Hospital, the entire staff, and the Jaika Theatre nursing staff and the health assistant who has been assisting for my surgical procedures, anesthetic department, consultant and the doctors who have given the anesthesia for my patients. Our patients, they have given us, they have participated in the study for the reality of this oration. Professor T. Kumanan, Professor M.G. Satyadas, and Professor Rajendra, their guidance was instrumental throughout the challenging journey of research and the manuscript preparation. Thank you, sir. This is my family who gave me a remarkable support during my childhood, especially the leader, my mother, Nesamalar Devaraja, a lady who stands among the 4 rugged men, manage them all with the affectionate skill. My tough elder brothers always push me to reach this stage. I strongly believe this remarkable lady takes pride in my journey, even from heaven, alongside with her better half, Mr. Devaraja, who has been my spiritual support throughout. Last but not least, my personal gratitude goes to my wife, the pillar through my ups and downs. Her immense sacrifice, balancing her career and always prioritizing our family have made me this journey possible. I deeply gratitude my loving kids for their generously understanding and giving up their valuable time with me to make this possible. Finally, thank you for the audience for the listening.